So today we're delighted to have, actually it's a twofer, and the hard thing to imagine is we're going to do assessment and treatment in one fell swoop. Dr. Tsatsanis is going to start with assessment, and I'm going to do a little bit about treatment, and this will be something we'll come back to. And it's a bit of a challenge, as you'll see, for actually both assessment and treatment. We talk in autism about, and Asperger's and related disorders, we're talking about a broad range of issues. We're talking about little kids, we're talking about older kids, we're talking about kids with very severe cognitive impairment, and to kids who are much brighter than most of us. So it's an interesting set of challenges on both scores, and Kathy's going to start off with assessment.
Right. So in this session, my main goal is to provide you with an overview of what's involved in assessment of autism spectrum disorders. I have 45 minutes to cover the topic, so bear with me if I start to speed up as I talk. But what I wanted to do was just orient us to start and say something about the terminology I'm going to use. So we're talking about a class of disorders, autism and related disorders. And the terminology we typically use in our diagnostic manual is pervasive developmental disorders. More and more in the community among lay people, and then also among professionals, we've moved to the language of autism spectrum disorders. So you may find that I'm using them interchangeably throughout the session. Now the interesting thing about autism spectrum disorders at this time is that there is no lab test or medical test that we use to diagnose the condition. So there's no medical or genetic or blood test or even neuroimaging diagnostic measure. Rather, the diagnosis is based on behavioral features, so how the child presents and what their clinical history is. And there are three main areas that we're looking at in terms of the behavioral features. And just to refresh your memory about those, one is reciprocal social interaction, the other is communication, and the third is restricted and repetitive behaviors. And I'm not going to go into these in detail, but just want to remind you of these three areas as the main areas that are the features we're looking at in terms of pervasive developmental disorders. More than this, within each of the domains, there are a number of specific features that we're looking at. So let's take, for example, that social domain. The kinds of features we're thinking of as we think about diagnosis include things like the child's nonverbal behaviors, eye contact, body postures and facial expression, whether or not they seek out other people to share their enjoyment, or whether they elicit interactions from other people. So the bottom line being that there are a number of different features that go into that domain alone. And then if we take the communication domain, there are a number of features that also present in that domain, whether the person has a delay in language, or if language does develop, they might have difficulty, especially in the higher functioning individuals, they have difficulty initiating or sustaining a conversation or having a back and forth conversation. Or we may find that the person uses scripted language where they're repeating over and again lines from a cartoon. And then the third category also comprises a number of different features. Motor stereotypies like flapping, for example, or rocking, repetitive behaviors where the person lines up, blocks or cars in a row, very narrow or circumscribed interest in a particular topic, like a deep fat fryers, for example, as an idiosyncratic one, and then various rituals, routines, or preoccupation with parts of objects like flicking of a doll's eyes rather than using it in a more symbolic way. The reason I lay all of this out as we go on to talk about diagnosis and assessment is to bring up the point that when we're talking about autism spectrum disorders, we're talking about three different critical domains: social, communication, and restricted and repetitive behaviors. And within each of those domains are a number of different features. And the number, the level of severity, and the combination of the features can differ from child to child. So we want to be able to both capture the symptoms or the features of the disorder, but we also want to be able to capture that variability. And that's where the assessment process comes in. So just before we get into what's involved in diagnosis and assessment, let's talk about one way of distinguishing the two or thinking about the two. So one question that may come up is, why do we diagnose at all? What's the importance of diagnosis and what's involved in diagnosis? I would consider diagnosis one part of the assessment process. And we can think of it in terms of that part of the process that's about classification, where we're taking a constellation of behaviors or features and we're grouping them in some way. We find that they tend to hang together. And they're consistent with a particular syndrome. And that disorder, that syndrome might be autism, it might be Asperger disorder, and so on. And what we want to be careful about is drawing a distinction between diagnosis and having that diagnosis and the person with the diagnosis. So we're careful in our language to talk about a child with autism rather than an autistic child. And the main point there is that the diagnosis is meant to capture only one part of that child, and it's about a group of features or behaviors that that child's displaying. It's not meant to capture the whole of who that child is. Now, there are some very practical reasons as well why we diagnose, and some of those include the implications for intervention, as well as legal rights in terms of access to different services. It can also inform us about prognosis, and it also provides a common language for different professionals to communicate amongst each other, and then also a common language for individuals and families. And so you'll notice in diagnosis, I have the disorders in different boxes. When we're talking about assessment, where I think of diagnosis as a process of classification, and here we're taking these features and we're grouping them together and we're saying, this represents a disorder called autism, this represents a disorder called Asperger's syndrome. When we think about assessment, it's less about classification or that general box that these things fit into, and more about the individual person and trying to capture that variability that I was talking about. So here with assessment, we want to capture in a more refined, in a more detailed way, the person's particular strengths and weaknesses. So, and that's an important point as well. We're interested not only in where they're vulnerable, but also what their strengths are. So I have here an autobiographical statement, because I think what's really nice for me about this particular statement is it not only captures the disability, but it also gives you a flavor of the person. And that's always the balance that we're trying to achieve. So here, this is from Robert, and that's not the person's actual name, but this is, my name is Robert. I am an intelligent, unsociable, but adaptable person. I would like to dispel any untrue rumors about me. I cannot fly, I cannot use telekinesis. My brain is not large enough to destroy the entire world when unfolded. I did not teach my long-haired guinea pig Kronos to eat everything in sight. That is the nature of the long-haired guinea pig. So the point here is that where diagnosis is about classification, assessment, we're trying to get a sense of who this person what this person's strengths and weaknesses are and how the disorder impacts them. And we collect that information through observation, through talking to people in the person's life, as well as the world of that individual. The last point I want to make is that we consider diagnosis and assessment as the first step toward treatment planning. So this is also, the second half of this talk is about treatment, and there's a reason why we have the two coordinated, and that is that the diagnosis and assessment process is really that first step toward thinking about treatment planning. And so we try to have intervention proceed from a comprehensive picture of what the person's problems and symptoms are, but also the challenges that are interfering with their functioning, and then in addition, the strengths that we can use to help in their areas of weakness. The approach we take to assessment is quite comprehensive, and in part by necessity when it comes to autism spectrum disorders. So this assessment model, or this approach to comprehensive assessment, involves a number of different elements. And the elements include a multidisciplinary team, assessing multiple areas of functioning, and collecting information across a variety of settings. And our goal in all of this is to try to provide a single coherent view of the person or the individual with ASD, one that we can effectively communicate to other people who are working or living with this person, and then also drawing a connection between our results or our findings and appropriate recommendations and goals and strategies for intervention. So what I want to focus on first are the 3 points in blue, and talk a little bit more about them. The assessment of individuals with autism spectrum disorders calls on the expertise of a wide variety of disciplines. And these include, but are not limited to, child and adolescent psychologists and psychiatrists, social workers, speech and language pathologists, occupational and physical therapists, as well as people from the medical field, including neurologists, geneticists, pediatricians, particularly when it comes to first detection or initial identifying those initial red flags. It can also include behavioral therapists and others. The involvement of this wide range of professionals speaks to the presentation of the disorder in and of itself. When you think back to that first slide of all the different domains of functioning that are involved, we see that this is a disorder that can impact multiple areas of development. And so it involves multiple professionals, and the assessment involves multiple areas of functioning. So in addition to having these different professionals involved in the assessment process, there are also different areas of the person's functioning that we want to capture. And this includes a developmental history, their cognitive or level of developmental functioning, diagnostic assessment, speech and language, assessment of sensory and motor skills, medical, and so on. All right. And the third part, I think, that's part of this comprehensive model is recognizing that the child or the adult or adolescent with ASD operates or functions in a variety of different settings. So there are a number of different settings in which they are learning and interacting with others, playing or working. And as it would be true for most of us, the children or the individuals with ASD may present differently in those different areas. So if you think of yourself at home versus how you present at school versus how you present at work versus how you function in these different settings, that there can be some variability, and that would be true for individuals with ASD. In addition, the settings themselves can vary. So the settings may differ. School versus home versus community may differ in terms of how familiar it is to the person with ASD, may differ in terms of the level of structure that's offered, the level of interpersonal support, as well as how complex the demands are in that environment. So as part of the assessment process, we want to also capture that variability, and we want to we're not interested only in a snapshot of the child at this point in time when we see them in clinic for the day or 2 days or 3 days that the evaluation takes place, but we want to have a sense of how they present across different contexts and with different people. And this information can be important and relevant both in terms of how the child presents in a consistent way across these different settings, but also if there are differences in how they present. And the differences in some ways can be almost more interesting and more valuable than the similarities. And it's not meant to say that the child is doing better at home than at school or doing better at school than home, but it really gives us a clue to what variables in the environment or what variables in the people who are working with the child might be contributing or maximizing their performance or their success in that environment. And so we may find that it lets us know that we need to increase the level of structure, or we need to increase the amount of routine in their day, or increase the number of visual supports and so on. So it all becomes information that informs the assessment. The last thing that we do, and we think is an important part of the assessment, is having a role for parent observation. And again, we're mindful that in this setting, in a clinical setting, we again have just a snapshot of that child, where we're seeing them at this point in time over 2 days in this somewhat artificial setting. And so the other thing that we do is ask parents or invite parents to observe the assessment. And the value of that is, one, recognizing that the parent is an expert on their child. And so this gives us an opportunity not only to have a common set of observations where we can share what we've observed with the parent and comment on that through the feedback process, but also whereby the parent can tell us the ways in which the child is presenting similarly or different than other settings they've seen them in. And again, that becomes really important information for us. For example, sometimes one of the things that happens quite frequently is that as part of our standardized measures, we ask the children questions in a very particular way. And parents will say, well, he would know the answer if only you asked it this way. That's really important information for us because it tells us on the one hand that the child has that knowledge, but that they need certain cues or structures in order to elicit it. And so one of the goals that might issue from something like that is a goal for generalization or expanding the ways in which they can access that information. All right. So we've talked a little bit about diagnosis and assessment as capturing both the features of the disorder and the variability. And what I want to turn to next is the different aspects of the assessment itself. And so I'm going to touch upon these areas here and then talk about differential diagnosis before we wrap up. Okay. In terms of the history, historical information includes developmental history, behavioral history, educational, family history, and history of treatment and interventions. Again, going back to that idea that we have a snapshot, we're getting a snapshot of this child, we're seeing them at this one point in time. One of the things we want to do is gather information about all the time that preceded this visit, so getting a sense of all of the other the developmental history of the child and all the other information that surrounds that child to this point in time. The historical information can be particularly important in terms of identifying were there any delays in this child's development. For example, when did first words first emerge? Are there any atypical patterns of development? So things that we wouldn't typically see in typical development that this child has shown or is showing. Are there any medical or genetic findings that would be relevant to how this child is presenting? And are there any skills that the child once had that they had gained and then lost? All of this information goes together and is informative as concerns the diagnosis and the differential diagnosis. And we collect this information through a variety of means. It can be through clinical interview. We also will collect records, so any of the past evaluations that were conducted for this child will be part of the clinical record. And then at times we'll also invite video recordings of the child's early development, particularly if there's concern about regression. So if it's come up that the child once had some skills and has lost them and looks very different than they had when early on in development, we might ask for video recordings of times, birthdays or other family gatherings to see what the child looked like at that point in time. All right. In terms of the cognitive assessment, the cognitive evaluation or developmental evaluation for younger children provides an opportunity to obtain a measure of the individual's overall intellectual level or their overall developmental level. One of the things to keep in mind is when we're talking about cognitive functioning or intelligence, it actually involves a variety of different domains of functioning. So what can go into an overall measure of a child's cognitive development or intellectual development are measures of their verbal knowledge and verbal reasoning, their nonverbal reasoning, their memory processes, speed of processing, visual and auditory processing, and so on. So it's actually not a unitary construct in that context. What's really interesting about that, and one of the most interesting aspects of working with children with autism spectrum disorders and conducting these kinds of evaluations, is the variability in their presentation as well. And this includes both the level of cognitive functioning and also the profiles of cognitive functioning. And these have very specific implications for how we select our tests, how we interpret them, and what it means for intervention. So let's talk a moment about levels of cognitive functioning. And this figure shows the normal curve, which I think most of you have probably seen before. The main points for us are that the mean is 100 and standard deviation is 15. And what that implies is that the average range is 85 to 115. For individuals with an intellectual disability, or what was called in the past mental retardation, a score of under 70 would place you in that category of an intellectual disability. In terms of level of functioning, what's fascinating about talking about this disorder, even though we have this unitary disorder called autism or autism spectrum disorders, the range of intellectual ability is extremely wide. It ranges from profoundly to severely intellectually disabled, all the way up to these upper extreme ranges. So even though we have this one classification or one disorder, we see tremendous variability in terms of the levels of functioning. And in the past, reports suggested that about 70 to 75%, so almost 3/4 of individuals with autism actually functioned in the intellectually disabled range. As the classification has broadened, we find that it's closer to about 55% who are functioning in the intellectually disabled range, and about 45% of individuals who are in the below average range and above average range of functioning. So in addition to levels of functioning that can vary and have this wide range, we also find that there's tremendous scatter within this domain as well, so that there are profiles of strength and weakness. And before I get into the details of these numbers, just to show you graphically, and you don't need to know the details of this other than to look at, for example, that green line, which stands out the most, you can see the tremendous peaks and valleys. This represents the average performance of a group of individuals. For example, for the green line, it represents individuals with high functioning autism on one cognitive measure. It's called the Wechsler Intelligence Scale for Children. And you can see on this one measure, unlike the typically developing individuals who show a more flat profile, huge peaks and valleys in the performance. And this is not at all infrequent in terms of kids with ASD. So it gives you a sense of not only the range in terms of level of functioning, but also the tremendous range, the highly discrepant abilities and disabilities that can be shown by an individual child. This level of variability requires us to be extremely cognizant of at least three things, and I'll touch upon those three. The first is we have to be really careful about how we interpret our global scores. So for example, here's a child with a full-scale IQ, so that would represent the global score of 102. That's almost dead average. If we were to say that this child was functioning in the average range, we would lose a ton of information about this child's cognitive profile. And here you see these different domains that went into the full-scale IQ. One is verbal, the other is nonverbal, working memory, and then speed of processing. And the scores range from 65 to 126, range from well below average to well above average. The idea here is that we don't want to lose that variability, and we don't want to interpret this IQ score in isolation. We really want to be able to capture what those strengths and weaknesses are. All right. The other thing I want to mention, I'm not going to go over these different tests in detail, except to say that we also, in addition to there being variability in terms of the levels of functioning and profiles of functioning in the individual with ASD, there's also various kinds of measures to assess cognitive functioning. These are some of the common test batteries. We have nonverbal measures and developmental assessments. All of these test batteries, so even taking the top group, all of these measure overall intellectual or overall cognitive ability. But what's interesting is that they may measure it in very different ways. So what we find is not only are there discrepancies, discrepant abilities in the child with ASD, but there are also differences in the way tests measure cognitive ability. And they can differ along these lines: the level of language skills that are required of that person taking the test, the degree of complexity of the instructions, the level of structure that's provided, for example, how much teaching is allowed on the test items, the extent of the social demand, so how much interaction there is when the person has to complete the item, whether or not time tasks are used, and how much motor involvement there is. So it becomes incumbent upon the person who's selecting and administering the test, as well as consumers of the information, to have an understanding of how these tests differ. Because you can imagine that given the discrepancy in abilities, and then given the various ways in which cognition can be measured, you can optimize or diminish a person's performance based on the kind of measure that you select. The other thing I want to mention in this context, in addition to thinking carefully about the scores that are yielded by these measures, we also want to be careful about integrating our observations with the test results. So the numbers are important, but they're not the end of the story. In some ways, they're only the beginning, and our observations can be as important, if not more important in some cases. We want to integrate our observations with the test results. And to give you a very concrete example, I'm going to ask you to do a little exercise with me. There's a measure. This is not part of an IQ test. This is a measure in a different kind of battery, and it's called category fluency. And you might have played a game kind of similar to this. And the category here is animals. And what I want you to do is think about, I give you a certain amount of time, like 60 seconds, and I want you to name as many animals as you can think of in that time. So what's the first animal that came to mind? Just shout one out. Dog, raccoon, cat, right? Those are the first. And that would be typical most of it: dog, cat, horse, raccoon, bear, and so on. So here's a young girl with Asperger's syndrome, and here was her first response: sulfur-crested cockatoo, Chesapeake Bay retriever, hog-nosed viper, desert tortoise, and so on. It almost became a test for me to see how quickly I could write down all of these responses. What's interesting about this is that, of course, she performed in the average range and probably even above average on this particular measure. But to talk about only that, we again lose a lot of information. We really want to think about the content and our observations as well. And here, the types of responses she gave are interesting, both in terms of hinting at maybe what was a special interest for her, animals, and also hinting at what might separate her from her peers, where most of us, and you would think most 7-year-old girls, might think about horses as the animal that first comes to mind. For her, the animal that first comes to mind is a sulfur-crested cockatoo. And while animals is a lovely topic for kind of shared interest among 7-year-old girls, if your kind of areas of special interest are these very specific animals, it could actually serve to separate rather than unite her with her peers. All right. The final major points I want to make about the cognitive assessment are their role in the evaluation and their implications for treatment. First, in terms of its role in the evaluation overall, the cognitive or the developmental assessment is a way of framing the evaluation. If we know something about the child's overall level of ability, it helps us interpret their behavior in other domains. So here's an example again of somebody who's got extremely good nonverbal abilities, slightly weaker verbal abilities, and then we see a huge gap between their very good intellectual skills and their adaptive functioning, and that is their social functioning in the day-to-day world. And then at a very kind of, in a very personal way, we see how that impacts them. And here's a quotation from a response on the ADOS, and here the person is talking about how they think about friendship. And her response was, "I realize that it is always a truce before the official friendship. It's very difficult to explain, but I make all the rules. If they follow the rules, it will guide them toward a path of friendship. But people are getting more slippery. If you tell them the rules, they follow them deliberately." So it really captures, I mean, numerically we capture the discrepancy, the stark discrepancy between the person's abilities and their ability to translate that into their day-to-day functioning in the social world. And then even more poignantly, we capture the struggles that the person has in establishing and maintaining friendships. All right. The cognitive assessment also has some very practical implications for diagnosis. Again, in terms of framing the evaluation, let's take, for example, say we see a child for assessment and their chronological age is 4 years, and we assess them and we find out that their mental age is 2 years of age, and their social functioning is also at about the 2-year level. While their social functioning is below their chronological age and may have led people to think that this is an autism spectrum disorder, the fact that their social functioning and their mental age are roughly the same suggests that maybe this is an intellectual disability, so this is someone who's globally developmentally delayed rather than it being autism specific. And obviously we would collect more information to make that determination. But this is one example of how the cognitive evaluation or the developmental evaluation can help to frame that picture. The second point is very concretely, again, the cognitive early developmental evaluations can identify whether there are any significant developmental delays. And this is important in terms of making a distinction between onset criteria for autism versus Asperger's disorder. So whereas in autism, the onset criteria specify delay prior to 3 years of age, the opposite is true in Asperger's syndrome. So we might look to that information for helping to make that differential. And then finally, level of cognitive functioning along with a level of adaptive behavior informs whether the child has an intellectual disability, and in fact is part of the definition of an intellectual disability. And then the last point I want to make here is the implications, is about implications for intervention. The other aspect of the cognitive assessment is to identify strengths and weaknesses in the child's profile. And we use those strengths and weaknesses to inform intervention. And let me just take you through a few examples. One is by identifying the child's areas of weakness or challenge, it can help to identify some of the goals and objectives for the child. So again, let's take a child who has a chronological age of 8 years, but we find upon assessment that their mental age or their developmental age is at the 2-year level. In that case, it gives us some information about where we set our goals. We want to set our goals and expectations to meet the child at their current level of functioning, at that 2-year level, rather than setting the goals and expectations at the 8-year level. And this is not to minimize or take away from or reduce our expectations for that child in the long run. The idea is to try to set the goals and meet the child where they're at in order to reduce frustration and help us work in a systematic way to get at those higher order goals. Another way in which knowing what the child's strengths and weaknesses are can be helpful in terms of questions about the child's behavioral presentation. So sometimes we might, for example, get a referring concern where one of the primary issues is that the child appears extremely inattentive and they're not following through on directions, and this is creating a problem, and people are wondering whether the child has attention deficit disorder. An assessment might reveal that even though that this child has really good verbal skills or expressive language skills, that their verbal comprehension or verbal understanding is actually quite poor. And so it's this difficulty in verbal comprehension, this difficulty in verbal understanding that's making them appear inattentive. So really they're not understanding what's being said as opposed to not being able to attend to what's being said. And then finally, another way in which the assessment can be helpful in terms of thinking about our recommendations is by identifying what the areas of strength are, because then we might want to draw on those strengths to help in the areas that are weaker. So let's say we have a child who has the opposite profile of the one I showed you in the slide. So now where their visual processing and their nonverbal reasoning are really strong and their verbal skills are very weak. We might want to draw on that strength in visual processing and use visual strategies to support their communication. All right. So now I want to turn to just briefly language and communication assessment. In terms of language and communication assessment, many of the same kinds of principles that I talked about for the psychological assessment apply. And because difficulties in communication are one of the central features of autism spectrum disorders, this becomes a central part of that multidisciplinary assessment. So if you think again back to those three bubbles, one of them was communication. So the communication assessment becomes a key component of the clinical assessment overall. And this is true for even for the higher functioning individuals with autism and Asperger's disorder who have who have language and maybe even good expressive and receptive understanding, but have significant problems in how they use language socially. And so the language assessment is focused on not only the formal aspects of language, so things like expression and comprehension, syntax, grammar, and so on, but also any atypical features of communication and the nonverbal aspects of communication, like the individual's prosody, the nonverbal forms of communication, how language is used to interact socially, and then also non-literal language. So some of the things in terms of thinking about the atypical features in the prosody, some of the kinds of features that come up specifically in autism spectrum disorders are differences in the prosody of how the person or voiced person speaks. It may be more flat or robotic. I don't know if you wanted to do, but
talking in a monotonic voice like this, often very loud.
So it's not only what the person is saying, but how they're saying, and that becomes an important, relevant part of it. The other is echolalia, so whether another feature that we sometimes see in individuals with ASD is echolalia, so repeating the same words over and over again. And then finally, scripted language, so where the child might have a favorite video like or cartoon like SpongeBob and recite over and again lines or from that video. All right. And just like the cognitive assessment, the communication assessment typically involves several components, and selection of tests and assessment procedures depends on the individual child and their unique circumstances. I'm not going to go into details about the types of measures because I think that will be its own session. All right. So the next major area that we look at is adaptive behavior. And adaptive behavior is actually quite distinct from what we think about when we're talking about intellectual ability. In addition to the tests of of overall development, of tests of intelligence, of speech and language that we conduct in the clinic, we also want to try to understand how that child presents in the real world in more typical settings, so not just in the clinical setting. And this leads us to a concern about adaptive behavior and attempt to measure that child's day-to-day functioning in real-world settings. And this is typically done by through assessment with a parent, and there are also classroom editions of the measures as well, where the teacher can report on how the child is doing it in the classroom. Again, this is lending us a real-world perspective. So not only whether that child can solve a problem on one of our measures, but whether they can solve a problem in the real world. One of the questions that comes up is what happens. So I said that IQ, intelligence, and adaptive behavior are quite distinct. So for example, in a very concrete way, a person may be able to do multiple advanced calculations in their head, but when they get to McDonald's and have to order a hamburger and a Coke, they have tremendous difficulty. So this kind of discrepancy is something that gets captured all of the time, and more often than not, we find that kind of child's intellectual ability is actually greater than their adaptive skills. And when this was measured in a larger group, so these are high-functioning individuals with autism, Asperger's syndrome, and PDD, all of whom were functioning in the average range and were about 12 years of age, what they found is that overall their adaptive skills, so how they were functioning in the real world, was well below their intellectual level. And their interpersonal age equivalent score was 3.6 years. So even though kind of chronologically they were at they were 12 years old, their intellectual ability was at that 12-year level. How they were functioning in the day-to-day world was significantly lower. Briefly, the main measure, or a measure that's often used to capture or to assess adaptive behavior is the Vineland adaptive behavior skills. And as you can see here, we're capturing information in several different domains. Communication, daily living skills, which would include things like brushing one's teeth, bathing, household chores, toileting, and so on. Then socialization, motor functioning, and maladaptive behaviors. What we find when you take measurements of, again, looking at some of the studies that have been done in this area, when we take measures of the child's social disability, so their symptom presentation, going back again to those 3 bubbles. So say we're trying to measure the severity of symptoms, and we're trying to measure how the person performs in the real world. We find that those 2 domains are actually not correlated, which is really quite surprising at first blush. So the kind of the social disability and the social abilities are not significantly correlated. And more than this, what we find is that over time, social ability in the ASD group is negatively correlated with age. So as the kids with ASD get older, their functioning in the real world declines, whereas their diagnosis or the symptom presentation might remain a little more stable. This becomes really important from an intervention standpoint, again, because what it means is we really want to prioritize adaptive functioning. We really want to be thinking about those real life skills. It's not given that there's this dissociation between the symptom presentation and real life functioning. If we were only to focus treatment on reduction of symptoms, we might not find, it may be the case that that wouldn't necessarily lead to any difference in functioning in the real world. So we want to, as much as possible, translate the information that we have into goals for functioning at home, at school, and in community settings. All right. Just a few words about assessment of symptoms. There are a number of different rating scales, checklists, and other assessment instruments that help us to capture some of the symptom presentation in autism spectrum disorders and assist with diagnosis. The 2 most widely used at this point in time are the Autism Diagnostic Interview Revised and the Autism Diagnostic Observation Schedule. The ADIR is a means of collecting historical information as relates to ASD or ASD symptoms, and the ADOS is a direct assessment of the child. All of this information is a means of kind of structuring and quantifying our observations, but ultimately we want to integrate that with informed clinical observation as well. And I'll skip over the details of the ADI and ADOS. Sometimes it can be challenging to distinguish the different disorders, and there are 2 challenges that present. One is making distinctions within the class of pervasive developmental disorders. So one part of differential diagnosis is differentiating between autism, Asperger's disorder, and other PDDs. And the other distinction is between PDDs and other kinds of disorders that might be presenting, such as an intellectual disability, a specific language disorder, and so on. So let me just touch upon that briefly. Among the pervasive developmental disorders, we have some very specific criteria for how diagnoses are made. And these include the number and combination of symptoms, and then also particular onset criteria that distinguish autism, Asperger's disorder, and PDD-NOS. So we're looking at both the number and severity of symptoms, and we're also looking at onset in order to make that distinction from a classification point of view. What's interesting is that in the literature, there's also some clinical features that seem to differentiate, especially in the high functioning individuals with autism and Asperger's syndrome. Now, this is still an area that is being discussed in the literature, whether or not these are two distinct groups of individuals. But thus far, there are certain features that have been identified that seem to be more characteristic of individuals with high-functioning autism and Asperger's disorder. And just to give you some examples in each of those domains. So for example, one feature, clinical feature that seems to present more frequently in high-functioning autism is, in terms of social interaction, is greater social isolation, a more aloof presentation, or a more passive presentation when interacting with others. Whereas in Asperger's syndrome, often there's greater social approach, and the person appears very interested in others, although the initiations might be very awkward. From a communication standpoint, just highlighting a couple of things, in autism we might see that more characteristic monotone speech pattern that Dr. Volkmar demonstrated, or we might see a history of absent or delayed language. In Asperger's disorder, by definition, early language skills are preserved, and what we tend to see is more verbosity, where the person is talking at you almost in a professorial or pedantic way. Another feature in the behaviors category that clinical feature that sometimes can distinguish individuals with high-functioning autism and Asperger's syndrome is the type of interest. So in autism, we might see some narrow interest or some splinter skills, so some very isolated ability areas, such as somebody who has excellent drawing skills, for example, and can reproduce a drawing in extreme and perfect detail. In Asperger's disorder, what we tend to see is some narrow, circumscribed interests that are all-absorbing and that tend to be the amassing of information about that particular topic, and kind of a dedication to thinking about and acquiring information on that subject area. All right. The other area, so that one area of differential diagnosis is within the PDD spectrum. The other area that we're sometimes faced with in terms of differential diagnosis is thinking about other disorders that might be presenting rather than an autism spectrum disorder. And these include, again, intellectual disability and language disorders, obsessive compulsive disorder, schizophrenia, and so on. And some of the, for each of these, how we make the distinction is more complex than what I'm about to say, but here are some of the things that we might look at. So for example, in an intellectual disability, we might expect to see a pattern of more even development. So where the person's language, their social functioning, their overall cognitive ability is more even. It might all be delayed relative to the person's cognitive, or relative to the person's chronological age, but we wouldn't see necessarily those marked discrepancies that we do see in pervasive developmental disorders. In language disorders, one of the things that we might see that distinguishes the child from a child with autism spectrum disorder is the use of nonverbal communication to compensate for the language impairment. So whereas in individuals with ASD, both verbal and nonverbal communication can be impaired in terms of social interaction, what we might find is for a child with a language disorder, they might have difficulty expressing themselves, but then use nonverbal acts to get your attention, for example, by tapping you on the shoulder to get your attention, or using eye contact to draw you in, or pointing to draw your attention to something that's of interest. And so using those nonverbal means to draw the person in and to elicit that social interaction, even in the absence of having access to language. In obsessive compulsive disorder, individuals will show a number of obsessions and compulsions, but there those compulsions tend to be experienced as a source of distress. Whereas what we find for individuals with Asperger's syndrome, for example, who do have a particular interest, and it can be obsessive in the sense that it's something that occupies their thinking and occupies their time to a great extent, what we find is that that's actually a preferred activity, something that's sought out, and so on. So these are some of the ways in which we think about the differentials. All right. So I've touched on some domains. What I haven't had a chance to go into more detail about, but are other areas of assessment that are equally important and would complement all of the different areas that I've just talked about in this session. And that includes behavioral observations across these different settings, behavioral assessment, neuropsychological assessment, occupational therapy and physical therapy assessment, assessment of the child's academic skills, medical and vocational, and so on. All right, and so to wrap up, just want to go over the main takeaway points from this session. So first of all, the importance of assessment. The main assessment is one component of assessment, as we talked about, is diagnosis. It's just one part of the assessment process, and there we're looking at a constellation of features that hang together and represent a particular diagnostic category. It's not the whole story, but it's an important part of the story, and one reason it can be important is because it allows a person to gain access to services. And here I've given you a few examples. So that can be access to services in the school in terms of idea categories and a label of autism. It can be access to government agencies such as the Department of Developmental Services, which was formerly the Department of Mental Retardation. It can also direct the person to government resources, national resources, and community resources. That could be quite helpful. And then more broadly, thinking about diagnosis and assessment as that first step toward developing a treatment plan for the child by identifying what their strengths and weaknesses are and developing goals from that. In terms of the assessment process, just a brief overview, it involves taking a thorough history, establishing what the child's developmental, cognitive, and language baseline are, assessing symptoms of autism, assessing adaptive functioning, looking at any medical issues and comorbidity, assessing sensory and motor functioning, and then again, as needed, doing a more comprehensive neuropsychological assessment, looking at academic skills, vocational skills, and so on. And then the final point in terms of the main issues in assessment of ASD and what I think makes it a really interesting group of children to work with is the varied levels of functioning that can present, the varied profiles of functioning, thinking back to those strengths and weaknesses or highs and lows in the profile, the idea that performance can vary across different kinds of settings and can even vary over time. And so this leads us to this idea that the assessment of ASDs should be ideally comprehensive and involve multiple disciplines, measures of the person's ability and disability, and collection of information across people and contexts. And finally, ultimately, what we hope as part of this process when we're operating as a multidisciplinary team and conducting the evaluation is we want to try to present a single coherent view of this child. And we try as much as possible to be in close communication with each other to avoid fragmentation and be able to provide this cohesive view that we can then communicate to the parents, to the school and other providers in this child's life. And then finally take our assessment results and think about those implications for adaptation and learning and ultimately for the child's treatment goals. All right, just in time. Thank you.